We live in a rational age where people like to feel they have complete control over their behaviour and act in a way that's in their best interests. If this were the case, we would all be walking, or perhaps running, around doing those things that we know are the right things. Instead, we all engage in behaviours that are bad: driving too fast, drinking too much, exercising too little. We know that these behaviours are bad, but we do them nevertheless. At work, the same rules apply. We don't always do the safest thing, and it isn't just because we don't know what the safe thing is. Washing hands too little, prescribing a penicillin without checking allergy status, failing to observe a patient often enough. We know these things are unsafe, but we sometimes find ourselves doing them. Guidelines, protocols, initiatives, new pathways, patient safety alerts, availability of new treatments, all require people working in healthcare organisations, whether that be primary care, mental health or acute care, to behave differently. The problem is that changing our behaviour is not always easy. Over time, our behaviour can become routinised. We don't give it a lot of thought. So if we have to do something differently, we have to stop doing what's become a habit and start doing the different thing. This means that we have to stop and think. If we don't, then we tend to do what comes naturally, the old behaviour. An example might help here. Let's imagine that you decide to stop taking sugar in your tea. For a week or so, you find yourself putting sugar in your tea without even thinking about it, particularly when you're distracted. So, new behaviours that replace old, well-learnt and practiced behaviours are difficult. However, in this example, at least the person wants to change. They have the knowledge and the desire. What happens though if the person doesn't believe the new behaviour will bring any benefits and might have some associated costs? Then, when they go to the cupboard to get the sugar, they may well think, "Oh, what the heck, it's not going to make any difference to my weight," and in the cup it goes. This is another reason why introducing changes in the way people do things at work can be difficult. People don't always have the desire to change. There are lots of things that influence that desire, such as our beliefs about what the benefits will be, what those people around us do and think, whether we think we have the skills and control to do things differently. So let's imagine we have a person who knows about the guidelines and really wants to change their behaviour. What else can get in the way and stop them? Well, Plato was onto one of these things. Our emotions can. Behaviours that make us feel bad are just not very rewarding, and we're unlikely to want to do them again. And behaviours that make us feel good, well, unfortunately, are sometimes those that are not very safe. Let's take an example from our recent work on checking the correct position of a nasogastric tube. The safest way to do this is to use a pH test of the aspirate from the stomach. But this made some people feel anxious, and they felt more comfortable if they could get an X-ray to confirm that the tube was in the stomach and not in the lung. Anxiety was leading people to do the risky thing, because misinterpretation of X-rays is the cause of most harm caused by nasogastric feeding tubes. Another example from everyday life is helpful. We all know that drinking excessively is bad for us, but for many of us it gives us a buzz. We can let ourselves go and have more fun. Finally, if our physical and social environment make engaging in the behaviour difficult, then despite knowledge, a strong desire and a good feeling about it, we may well struggle to do the behaviour. If pH testing papers are not available, for example, the temptation to send for an X-ray grows. If we know there isn't a doctor available to check a prescription, we're likely to get on and do it ourselves. If hand gel isn't available, we're less likely to practice good hand hygiene. If smoking cessation services are not available, we may be unwilling to refer a patient who needs support. We work within a system that constrains our behaviour. So, what is the lesson here? Behaviour change is not straightforward. If this is the case, then we would expect attempts to change behaviour would be well considered and tackle the problems that people experience when change is required. We've now asked more than 200 health professionals and managers in Yorkshire and Humber what happens when behaviour change is needed in their organisations. They gave us the following responses. They said that emails are sent, posters are put up, the change is discussed at meetings, practice is audited and training sessions are scheduled. All are well-intentioned, but these educational interventions are aimed almost entirely at increasing people's knowledge about the change. They focus on changing knowledge and reminding people what to do. In other words, these interventions ignore many of the influences on our behaviour that we've just discussed. Over the last 2 years, the Quality and Safety Research Group and the Academic Health Science Network Improvement Academy have pioneered a new approach to behaviour change that recognises the many influences on behaviour. We've worked with teams across the region to develop behaviour change interventions that are based on theory and evidence, and we have demonstrated safety improvements as a result. To find out about what we've been doing, or to sign up for one of our behaviour change workshops, or perhaps access our behaviour change toolkit, visit the Academic Health Science Network Improvement Academy website at www.improvementacademy.org.